All right, good morning, everybody. Can everyone hear me? No, not at all. Does this come higher? Ah, is that better? Okay. All right, so my job today is to talk a little bit about pediatric trauma. I can't swear that it's all going to be relevant to disaster preparedness, but certainly which in a disaster scenario certainly could be part of it. So today wanted to talk a little bit about the epidemiology. Why is this important? I know you guys probably know it's important and that's why you're here, but just going over some of the numbers. Looking at special pediatric injury patterns, how are they different from adults? What to think about in terms of differences. One of the new things I wanted to talk about was imaging in pediatric trauma, use of CT scans, how to decide when to use them, when not to use them. The new push in radiology in kids is to try to avoid radiation when it's not necessary. So how are we going to decide when it is necessary without scanning everybody? The ABCDEs, so a lot of you probably have ATLS. This is our alphabet of trauma that we use for adults and peds. And again, what are the differences in peds ABCs versus adults? A little bit about pediatric pain, and then I know there's a whole talk on pediatric triage. I'm not going to go into a lot of detail. I just wanted to talk about the CDC guidelines and then the New York State guidelines in terms of where they want these kids to go and how they want to be managed. So most babies die from congenital anomalies under the age of 1. Above the age of 1, it's trauma. Number 1 killer, hands down. You can take the other top 5 causes of death in children, add them together, trauma still kills more kids. So you can see half of deaths under 15 years are from trauma. Most of them are from car crashes. Although, I'm not going to try the M again. Although in that, I believe they also include, a ped struck, a kid who was in the car that got in an accident, someone on a bike hit by a car. So any kind of accident involving a car goes into those numbers, okay? Drownings, suicides, trauma starts to get up there, and that's in the teenage population. Okay? In-hospital mortality is low, so if you can get the kid to hospital, often they do pretty well. But the mortality in the field and pre-hospital can be significant. They've estimated the last time CDC did this, which was, I believe, 2008. The 2012 data is coming through, but it hasn't been fully finished. 20 children in the United States die a day from an unintentional injury, traumatic injury. And that's just deaths. So what about the injuries? I mean, we haven't even calculated that. So they've looked at sort of the long-term outcome of kids involved in trauma. At least a half of them will have some kind of long-term disability. So at 1 year, 50% of them had either a physical or cognitive disability. The siblings of these kids, parents are split, the kids are in hospital for a long time, family stress. The siblings are affected. 2/3 of them will have emotional disturbances. For parents, how do you manage your marriage and the other kids and the financial strain and work? This is a huge burden on the parents. And marital strain is an inevitable part of all that. So these are all the other things that go along with the one child you're treating, but you're not just treating that child, they're part of the family and part of the community, and the ripple effects are huge. Why are children so vulnerable, right? Children are curious, that's how they learn, they're built that way. Unfortunately, they don't have the judgment to decide when curiosity is going too far. That combined with their physical differences to adults makes them extremely vulnerable. Teenagers, it's the decisions they make, the crowds they run with, they start getting into the violent crowds, and that can cause problems. So in children, falls are the most common mechanism. Luckily, they're not usually falling from a huge height, so they're not often dying from their falls, but they're going to end up in the ED and need to be managed, okay? And then violence in older teens, and that's where you end up with your homicides. We're going to talk about why a child who sustains an injury is more at risk in the other slides. So what can we do as medical professionals? The primary goal really is prevention. If we could stop children from getting injured, that's the real way that we can solve this. So all of you should be out in your communities. If you see a kid on your block riding without a helmet, talk to the kid, talk to the parents. I know this is the zone of ATVs and snowmobiles. Kids should not be riding them. So, it's part of our job to sort of set the example and give our knowledge to the people in our communities and try to prevent. But that won't be enough. We know that won't be enough. So our next job as medical professionals is to minimize the morbidity and mortality of these kids. So this is where we talk a little bit about how kids are different from adults, what injuries they're more susceptible to. Kids are so much smaller than adults, okay, and they have a much smaller body mass. If you can picture a car bumper hitting an adult, okay, sure, you're going to get the leg. The same bumper hits a kid, you've now got their entire torso, hip, as well as thorax. And the mass is so much smaller, the force concentrates on a smaller volume, and it's a higher force per unit. So the same tissue gets much more force in a child compared to an adult. Multitrauma is the rule because of this, okay? You can picture this. You take an apartment building and you swing a wrecking ball at it, you might knock out a wall, a window, okay? You swing it at a house, you're gonna knock it down. It's the same thing with kids. You know, an adult, sure, they break a leg. A kid, you've now caused multiple intra-abdominal, thoracic, and head injuries for the same amount of force. How are they different? So this is what adults have. Adults have the fantastic suit of armor, a nice ossified bony skeleton, okay? It protects the organs of the chest, it protects your liver and spleen. It's an important part to why their traumas don't result in significant injuries. For children, they have mostly an elastic skeleton. Especially younger children, they're largely cartilage. They bend. It doesn't give the same protection, so they don't have that nice suit of armor. Children don't have the subcutaneous tissue that adults have. They don't have the same muscle mass. They don't have that soft tissue to help absorb the force of the injury. More force is transmitted into the internal organs because they don't have the extra tissue on the outside. So you've gotten the child, now you've got to examine the child. This is very different than an adult. An adult, how do you feel? Where does it hurt? Okay, you have a 3-year-old you're trying to take care of. You can't just walk up to them and say, where does it hurt? You're not going to get anywhere. So this is one of the big differences, especially with young children. They have very different reactions to pain, reactions to strangers. You have to start slow, go in slow. If you can invest a couple of minutes at the beginning, going in easy, try to befriend them, talk about Sophia the First, try to find something to get them on your side to show that you're their friend. That can then buy you a lot of credibility to let them actually examine you if they can get comfortable with you. So that's one of the big things with kids. Use the parent as your ally. We're often worried that it's going to be too traumatic for the parent to be in the situation with a significantly injured child. Evidence would show, however, that most parents actually benefit from being involved and from seeing the child. Some don't. So you give the parent the choice, and if they're completely unable to contain themselves and it's going to make things worse, then no, they're not going to be helpful. If they want to be involved and they have enough control to actually help you, get them involved, have them with you. If mom's next to you, child's going to see that you're a friend and not a foe. So if you can, involve the parent. And a big thing, and I found this really hard, is controlling personal emotions. There's a visceral reaction to an injured child, especially most of us have children. You have a child at home who's the same age, looks just like the kid who's rolled into Emerge. How do you control yourself? It's really hard, but somehow you have to separate yourself away from the situation, get through it, and then decompress afterwards. So a big part of pediatric trauma really should be having a group decompression afterwards, talking about it and getting the emotions out, because during it you have to kind of keep control. And here's the question, scan the patient. So you're in the ED, you've assessed the child, now you have to make the decision, am I throwing them through the CT scanner or not? Okay? It's usually considered pretty much the gold standard for identifying most traumatic injuries, and all of us are worried about missing an injury. What's going to happen if we don't pick it up? Part of that is because we're worried about mortality. Part of it is also, litigation in the States. You miss one little thing and you're nailed to the wall. So there's been a big push to scan everybody, and not just to scan everybody, but to scan the whole of everybody. If you're going to scan the head, well, why don't you just scan the chest and the abdomen? In kids, we're trying to move away from that a little bit, so we will talk about that. And also in terms of a disaster scenario, this is a big thing. You only have 1, maybe 2 scanners. You need techs to run those scanners. At night, you may not have a tech in-house. You have more than a few kids roll in. How are you going to decide who gets scanned first? Who actually needs those scans? And we will talk about that. So risk of malignancy. The risks aren't gigantic. So the lifetime risk is maybe 0.18%, 0.07%. But the number of scans that are done in this country means that there are kids that are going to die from cancers because they went through a CT scanner. So you want to make sure that that scan that they got actually gave information and was actually worth it. So 500 deaths from cancer due to CT radiation in the country was an estimate. Now that will be higher than it is now. The amount of radiation people are using, the scanners are better, they don't have to be exposed quite as much. So I think that estimate is higher than it would be for now, but it's still a real risk. So 50 milligray, that's way higher than any of the scans they're getting now. I talked to our radiologist. It's probably more like 15 gray to go through the scanner to get a CT abdomen now. So you'd need a few CT scans before you're getting, you know, a dramatic increase in leukemia. But it's still something to think about. And we will get back to this, but if you're going to scan, at least have a thought about it. Make sure that it's going to be the best scan. Is it needing IV contrast? Do you need oral contrast? Just make sure that it only gets done one time. This is a problem we even have where I work. Sometimes in an attempt to decrease the radiation, you decrease it so much that now you can't even tell what you're looking at, and you have a grayscale. So there's a balance there. And then we're going to talk about clinical decision rules when we go through each body system. So ABCDEs, airway, breathing, circulation, disability, and exposure. We're going to talk how that works into the pediatric trauma resuscitation. So airway. Kids have this gigantic head, this big tongue, all this soft tissue in their airway. In fact, the tongue and the soft tissues of the mouth in a kid who's obtunded are actually the most common cause of an airway obstruction. So to be aware of it, position them, the jaw thrust, consider use of an oral airway if a child's really obtunded and obstructing with their tongue. Be really careful of the soft tissues. Not only are they larger, they're friable. So any manipulation you do in the mouth, if you make it bleed, now if you do need to get an airway, it's going to be much harder to see and there's going to be swelling. So just be aware of those tissues and be gentle. The airway is completely different in a child. It is funnel shaped, so the narrowest point is at the cords. It also sits anterior. So a straight blade is going to be better than a curved blade. You know, you're going to need to be expecting a slightly different view. It's not going to slip in the way you do with adults. And everyone who deals with peds airway, I'm sure, knows this, but I'm just putting it on the slide so it's out there. Children also have a very sensitive gag. So the rule is, unless the child is really unconscious, you shouldn't be using an oral airway to support because you're going to make them vomit. Just an extra thing to think about. Because of the soft tissues and the size of their mouth, you're not going to be able to place the oral airway the way we normally would in an adult. You can't push it, you can't put it in and then flip it. You're going to have to probably use a tongue blade or open the mouth and stick it in directly just so you don't damage the other soft tissues. So you need to intubate, you've decided. So what things are going to need intubation? It's the same as with an adult, really. There's nothing different with peds. The airways, they're swelling in the head and neck. You think you're going to lose your airway, you protect it. You know, the child has a head injury, they're obtunded, they need intubation. They're hypotensive, they're sort of starting to lose consciousness because you know that they've got a bleeding injury, they need intubation. That's not different. The things that are different is they will desaturate much more quickly than an adult. So you have to really, really pre-oxygenate. Usually you'll have the time because you're managing the airway. Bag valve masks can be very effective. Get them pre-oxygenated while you're getting everything else ready, and make sure they're been sitting at 100% for a little while before you try, because they're going to drop like a stone as soon as you take the oxygen off. Protect the C-spine, same as adults. Correct tube size. So most EDs have that Breslow tape on the bed, so the kid goes on the Breslow tape. That'll tell you what size to use it. The Breslow tape's lost, you can't find it, or it's a disaster scenario. 2 kids already on the Breslow tape, you can't find one. What do? Okay, size of their nostril, size of their baby finger. It's a guess. Get the next tube up, the next tube down. One of those tubes is going to be a good tube. We used to say the teaching of ATLS, when I learned ATLS, was never a cuff tube. We don't use cuff tubes in kids ever, ever. The pendulum's swinging. Less than a year, probably stay uncuffed because the tissues are so delicate that they could be damaged. Once you get into the toddler age, even then, cuff tubes are probably fine. Just don't put too much pressure in the cuff. It's going to improve your ventilation. It'll protect them from vomiting. So I think a cuffed tube in someone who's comfortable with an airway maneuver would be very reasonable. A child's trachea is very short compared to an adult. So you risk both sticking it down a main stem, irritating the carina and causing them to cough, or being really too careful and having it really high. So confirmed tracheal placement and tidal CO2 should be in place for a child once they're intubated. Obviously, you're going to listen, make sure you're getting equal breath sounds, but they really should have end tidal CO2. If there's any question, just do it again. You don't want it in the esophagus. You don't want to keep it down a main stem. Redo it if you're not happy. Recheck with every move. That means every time you transfer the child from the bed to somewhere else, if they get onto the CT scanner, when they come off the spine board, every single time you need to check and listen, because small movements of the head, especially in a younger child, are going to get that tube going down the right main stem or popping back up above the cords. So you just always check, always check, always check. On to breathing. So this is your time to assess for a chest or pulmonary injury. They're not common, but because they can be catastrophic, they're actually the #2 cause of single system. So if we're talking single system injury, thoracic injuries are the #2 cause of pediatric death and trauma. In adults, you don't see any chest fractures. You usually think, okay, we're probably all right. In kids, that doesn't apply. As we talked about, they're cartilage mostly in the chest. The chest can completely flex and relax without a fracture. So you have to have a very high index of suspicion for an underlying pulmonary contusion. If there is a fracture, you need to be really worried. That means there's a gigantic amount of force applied to this child, and chances are the lung is not the only place you're going to find an injury. If they have a fracture of one of their ribs, they are going to have multi-trauma. There will be something else, and you just have to find it. Look for it and find it. So we'll talk about these clinical decision rules, but worry about mechanism of injury and external signs of injury. Don't look so much at the chest film for the rib fractures in kids. One of the pitfalls of managing the breathing, and this is more in the pre-hospital setting when they don't have ventilators and they're hand ventilating, with the adrenaline that goes with a pediatric resuscitation and the fact that you worry that you're not going to ventilate them enough, the problem tends to be overventilation. And so certainly in the pre-hospital, they talk about sort of a breathe, rest, rest to give them time to exhale so you're not filling them full of air and hyper-expanding them, causing barotrauma. So chest x-ray is good and bad. You know, it will find some of the pulmonary contusions. It will help you find a pneumothorax. It's going to miss any of the really central mediastinal injuries, which are the life-threatening ones. So how do you decide when you go on to a CT scan? It's very sensitive for those things, but as we've mentioned, there's radiation risk. Plus, in younger kids, if they're not obtunded, you're going to actually have to sedate them to go in the scanner. Otherwise, you'll never get a picture because they're going to be moving all over the place. So this is a large study they did with about 1,000 patients. And you can see here that pulmonary contusions and the rib fractures are the most common. The most common life-threatening one in a child is actually a tension pneumothorax. And that's a lot more common in children than in adults. Everything is more flexible. And there's less attachment in the chest. Things are more likely to move and tear. So a tension pneumothorax is more likely in a child than in an adult, just to be aware. You can see that the cardiac and aortic injuries are very rare, but they're not zero. So they took all of those 1,000 patients and they multivariate logistically regressed it. Some statistician played with it and looked at what were the most common signs that were going to tell you there was a problem. What were you going to look for? So this is what they came up with. And the way this works is if your child has any of the above, they get a CT scan. Only if all of them are negative and you're happy with the child could you consider leaving them alone, no scan, just chest x-rays enough. So any sign of hypotension, abnormal respiratory rate, abnormal thoracic exam, and that literally was everything from bruising to tenderness. So any external signs, any tenderness on exam, that counted towards raising your suspicion. If there was abnormal breath sounds, clearly a femur fracture. Again, a sign of force. So that's a large amount of force. You worry about injuries in other systems. Or if they're an unreliable exam, so the GCS isn't 15. Any of those, if you can say no to all of those things and you think the kid looks good, fine. Don't have to scan them. If you're suspicious and any of these are positive, that would be reasonable to proceed with a CT scan of the chest. So how does that rule work? In that population, and then they tested it on a second population, it identified 78 out of 80 injuries. The injuries that were missed were mild pulmonary contusions, and one was, I think, a small pneumothorax. They weren't clinically relevant misses. It caught all of the life-threatening aortic mediastinal injuries. Specificity is not great, but the sensitivity is good. So if there's an injury, you're going to find it with this rule. And the reason they found the other injuries were abdominal CT scans. So they'd had a reason to scan them for anyway. So again, these rules are more not about if one of these is positive, okay, I should send them to the scanner. It's more about reassuring yourself that I felt good about this kid already. I just want to make sure I go through the rule. Yeah, you're right. They don't meet any of the criteria. We're probably good to just watch them. That's the way these rules are supposed to be used. Okay, circulation. So this is really where you answer the question, is there bleeding? And if there is, what do I do about it? The problem with kids is vital signs can mislead. They have these lovely, pristine blood vessels that can, vasoconstrict at the drop of a hat. So they can really be tricky. Also, you have a child who's tachycardic. Well, why are they tachycardic? Is it hypotension? It might just be they're totally freaked out. Okay, the mom's not there, they're in pain, they're scared. So how do you tease that out? In adults, we look at hypotension, right? Any signs of hypotension, we can grade it with, how much blood they've lost. Unfortunately, in kids, they can really maintain their blood pressure for quite a long time. And then all of a sudden, now you've lost adequate blood and they're falling off the cliff. Once they're off the cliff, it's very hard to get them back up again. So you have to have a very low index of suspicion, really be searching hard to find signs of bleeding. So if you can't use their vital signs, what are you going to use? Mottled skin, and that's a picture of what that looks like, this reticulated sort of pattern. Are their hands and feet cooler than their central core trunk? Thready pulses, that's always a tough one for me. In the field, it's hard to sort of say. That I find a little less helpful. Prolonged cap refill can help, though. The caveat being, if your child is cold and has been exposed and hasn't been warmed up yet, is that why they're cold in their periphery, or is it because they're hypotensive? So again, not slam dunk answers. In kids, they are more likely to demonstrate CNS signs of hypoperfusion early. So any signs of abnormal reaction, could it be a head injury? Yes. Could it be hypotension? It very well could be. So if you look at the whole picture together, it should guide you to be more or less suspicious of some kind of a bleeding problem. So let's say you've decided, yes, there is a bleeding problem, or at least the child is showing signs and you're worried and you want to give them some fluid. In kids, it's weight-based dosing. You don't just obviously say, oh, give them 2 liters. If you have a strapping 15-year-old football player who got, an abdominal injury, fine, 2 liters is great. If you have a 3-year-old who just fell off their bike and hit their head, 2 liters is probably not a good idea. So again, your Breslow tape is your best answer. Unfortunately, because of the changing shape of American kids, sometimes it's not the most accurate because it'll sometimes underestimate. Children are sometimes wider than they are long, but it's the most accurate thing we have so far. The parent you can ask, they're going to tell you in pounds, so then you have to do the math to kilos. 2.2, I would just use 2, it's easier math, and you'll get somewhere close. The key in resuscitation is partly to use the weight-based, but partly to make sure that it's warmed, okay? Children, you can't give them cold fluids. If you give them cold fluids, you're going to make them cold. It has to be warmed, and everything should be warmed. So the air in the machine that you're doing, if they're on a ventilator, should be warmed. The saline, the blood, everything should be warmed. And you can, like adults, anyone who's done ATLS, we talk about responders, transient responders, non-responders. In children, it's exactly the same thing. So you can give them a couple of boluses of saline. By then, they really should be responding. They should really be showing signs. If it was their vital signs, they should be improving. If it was the modeling and the sensorium changes, those should be improving. If they're not, you should really be thinking about blood. So again, how are you going to tell? Follow the physical signs that you looked at in the first place, and those should all be improving. Venous access in kids, very difficult, especially in chubby toddlers. Finding a vein is impossible. I don't know how the nurses in the hospital do it. Doing it in a child who's injured and shut down and might be hypotensive is close to impossible. So your interosseous needle is going to be your big helper in this. What the ATLS guide says is you do 2 attempts at a peripheral line. If you don't get it in, you're going for an IO. Their recommendation is to do the anteromedial tibia as shot number 1. If that doesn't work, the second try should be the contralateral anterior tibia. So the femur is your second option until you've exhausted both lower extremities. Obvious caveat being, if they have a femur fracture or a major trauma on one leg, you're not going to do an IO on that side. You only have the other leg to work with. So now we'll talk about how do you figure out whether the circulatory problem is from an intra-abdominal thing. For me, that always goes under C because usually that is the biggest source of bleeding if you don't have anything external in a child. So physical exam. So they've actually done studies. So how good is your physical exam in determining whether or not a child has an intra-abdominal injury? It's all about the GCS. If you have a child who's fully alert, GCS 15, sensitivity is 80%. You're going to pick up most of the injuries that exist. As soon as you get a lower GCS, you can see your sensitivity drops dramatically. You're going to miss injuries for sure. So if you have a child who's got a decreased level of consciousness, even a mild decreased level of consciousness, you have to be thinking about more imaging. Isolated abdominal tenderness. So this is in a child with a GCS of 15. They have nothing else. All they have is pain or tenderness in their abdomen. The injury rate's 8%, which is still a pretty significant injury rate. So even if that's all they have is a little bit of tenderness, that should still make you suspicious. What about a seatbelt sign in children? We always worry about seatbelt signs for signs of internal injury. Everything gets pushed up against the vertebrae, and the problem we have in children versus, well, adults don't wear their seatbelts properly all the time, but children often have slipped down under the seatbelt or they're wearing it sort of in a funny place, so different organs can be injured in children compared to adults with a seatbelt injury. Unfortunately, as you can see, how predictive is it? 25% sensitivity. So that means you're missing 75% of the injuries by just relying on a seatbelt sign. Or you're missing some because the specificity is better, but you'll see the sign and it won't have an injury, and you can't tell whether there is or isn't one based on a seatbelt sign. It's just part of the whole picture, I think, is what I'm trying to say. There is a higher rate of intra-abdominal injury, especially hollow viscous. So in children, there's about a 10 to 15% rate of hollow viscous injury if there is a seatbelt sign versus a 1% rate if there's not a seatbelt sign. So the seatbelt sign really is a marker more for that hollow viscous injury than for anything else. So you've used your physical exam, now you have labs at your disposal. So the thing they've looked at the most is your liver enzymes, your AST and your ALT. Everybody's tried the multivariate regression to find the point at which you can do a cutoff. There's no great cutoff sign. It's not a good enough test that it can really help you decide, no, I don't need a CT scan, or yes, I do. The one place where it will be helpful, though, is it looks like if you have a child that you think was abused, who has no physical signs, if your LFTs are normal, you could be fairly certain they don't have an intra-abdominal injury and not scan them. So that's the one case where your liver enzymes probably will actually help you avoid imaging. Otherwise, if it's an actual car crash or multi-trauma victim, they're part of the picture, but they can't guide you. There's no cutoff. FAST exam. We know in adults the FAST is now an absolute part of our trauma exam. Unfortunately, and this is just where they're looking. So the idea of the FAST is to look for free fluid in the abdomen, as well as the pericardium. Most of the time it's going to be blood. Could it be, gastric or contents or intestinal contents? Yes. But usually it's hemoperitoneum is what we're assuming we're looking for. In children, it's not as good, unfortunately. So the sensitivity is only 50%. I had to go back up and look sensitivity and specificity up again, I will have to admit. So sensitivity means how good is it at picking up something that's really there. So if your sensitivity isn't good, it means that if you get a negative test, it doesn't really help you. You could have missed it. If it's good specificity, it means that if you get a positive test, you're pretty sure there is something there. So if you get a positive test, there's a hemoperitoneum. If you get a negative test, go to the next step. You're really not sure. They've tried to put it into rules using the transaminases again and combining them. There was one study that looked at a positive FAST plus the elevated liver enzymes. That got your sensitivity up to 88%, which is a lot better. So again, the more findings you put together, the more you get a complete picture of whether the child is injured or not. This study sort of said, well, 88% is pretty good. So let's say you have a normal fast and normal transaminases. Maybe you can just observe the children instead of scanning them. If you have the space and the time, it's possible. I don't think there's enough evidence from this one study to say that that should be standard of care. So the CT scan. This is our standard. This is where we identify our liver and our spleen injuries. This is how we decide how long to put the kids on bed rest for. But does everyone need a CT scan of their abdomen? And the problem is, it's great for your solid organs. It's really not good for your hollow organs. You can get free fluid from all sorts of things, not necessarily from bowel rupture. So you get some peritoneal fluid and the solid organs are okay. Maybe it's from a bowel injury, maybe it's not. Does the bowel wall enhance? Is there extraluminal gas? That for me is the strongest sign. If you have gas in the abdomen outside of the bowel, you probably have an injury. The other ones are all very soft signs. If all you have is free fluid and everything else is fine, your surgeon will be making the call for you, but those are the kids that will probably get observed versus operated on. This is the corollary to the thoracic slide that I put up before with the number of thoracic injury. This is a 12,000 patient review, retrospective, of course, of trauma patients. You can see liver and spleen are the most common, which we know. Some studies, liver is more common, sometimes spleen is more common, but they're the majority of your injuries. Gastrointestinal tract, 15%. So your hollow viscous, half as few as the solid organ. Peritoneal fluid is a good sign, 75%. So if you see that, you have to be suspicious. So they took all of that and they put it through their multivariate regression and they came up with a prediction rule. So if there's any signs on the outside of the abdominal wall, if there's any GCS less than 14, tenderness, if the thorax is involved, if they're having pain, decreased breath sounds, vomiting. Again, if any of these are positive, you should consider CT scan. If all of these are negative and your patient looks good, maybe you can avoid a scan. That's how you're supposed to use this rule. The sensitivity was very good, 97%. So if all of those were negative, you were very unlikely to be missing any injuries. So that's why they can say if they're all negative and you're happy with your patient, you're probably okay to just watch them and not scan them. Okay, disability. Head injury is the most common cause of death in children. They have big heads in terms of the body mass, the mass in their head compared to their body, very different than in adults. Especially in the younger children, their ligaments and muscles in their neck are not as strong. The way the spine is formed, their facet joints haven't set properly, things are still more likely to slide. So a head injury is much more common, as is C-spine injury in children. The brain itself is different. It has less of the myelin and the padding in the brain, so for the given trauma, their brain is more susceptible. And unfortunately, because the brain is growing, it's more metabolically active, so it's much more sensitive to hypotension. So any child with a possible head injury, you really need to be right on top of their circulation and make sure that they're fully resuscitated. Avoid hypotension at all costs. So this is a slide about the decision rules for mild head injury. This is not your severe head injured child that gets a CT scan. What this shows me is that people have a lot of time to come up with acronyms for all of these different studies. The PECARN is one that I read a lot about. Pediatric Emergency Care Applied Research Network. And so they are really doing a lot of work at these decision rules, trying to help emerge physicians and acute care providers decide which kids need more attention, which kids need less. They have the best decision rule out there for mild head injuries, and theirs divides the kids into 2 age groups. So it's either 2 or under or greater than 2. And there's slightly different criteria. And the study they did was they excluded all the kids with trivial head injury. So the kid was running and he fell and he hit his head. Yeah, he doesn't need a CT scan. We're not even going to include him in the study. Or he was running backwards and he ran into the TV and hurt himself. He doesn't need a CT scan. It was for anything with a mechanism more than that, but that was clearly not an obvious CT scan. So only GCS of 13, 14, and 15, that was what they included. Or wait, no, just 14 and 15. So this is for the little kids. So if the GCS wasn't perfect, any sign of mental status change, or if you could feel a skull fracture, they need a scan. don't even think about it. If they've got a real hematoma, if they actually lost consciousness, if there's a mechanism that makes sense, you know, if they have a femur fracture, if they have multiple rib fractures, I just scan them anyway. Anything like that, you can consider observation versus CT based on, you know, physician experience. If all of those are negative, you can sit tight. So again, these rules are mostly to help you feel comfortable sitting on a patient as opposed to telling you exactly who needs a CT scan. And what happens is, so in the GCS-14 group, the top group, the risk of injury in them was about 15% that you were going to find something on a CT head. So that's a high enough rate that it's worth CT scanning those kids. Coming down to the second group, so if their GCS was fine, no skull fractures, but they had some of the second group signs, the rate was less than 1%. It's 0.8 or 0.9% rate of injury. Not very high, but could be a significant injury, so enough that you, with discretion, could scan them. If all of it is negative, it's less than 0.05% risk of finding a problem. So really, you're not going to miss something if you watch these kids. This is the rule for the older kids. So again, now we're not talking about palpable skull fracture because you're not going to get that in the older kids. Now signs of basilar skull fracture. So do they have fluid coming out of the ears and the nose? Do they have the battle sign? Those are the things you're looking for. If those are positive, again, 15% rate of injury, 14% rate of injury, scan them. If they're vomiting, if they have a headache, if they're complaining of those sorts of things and you have concerns, still worth scanning them, but the rate of injury will be less than 1%. If all of those are negative, you're probably not going to miss anything because it's a very, very low rate of pickup on a scan for those kids. Think C-spine. So I mentioned it a little bit before. The rate of spine injury in kids is not high, but of those injuries, a large portion of them are going to be in the C-spine because of that large head on sort of weak neck. This is a problem though. You have something called pseudosubluxation. So you get your spine x-rays and now you have to decide, oh, well, is this a normal variant or is this a problem? So you can see on that x-ray, does this work? You can see that the front of C2 is forward on C3. Am I showing you where it looks funny? I can see it on here, but it looks shifted forward, so you'd be worried, well, was there a subluxation of the spine? This is a normal variant, 40% of kids under the age of 7, and it extends even up into the teenage years. It's made worse in flexion. So if you have the kid with a big head who's sitting there without something under their body, their head's going to flex forward, and this is going to be a possibility on an x-ray. So one of the things to do is to make sure you have a pad under the body so that their face, the plane of the midface, should be parallel to the bed. If their midface looks like it's sniffing up, then that's improper positioning and more likely to result in a funny-looking x-ray. Reposition them and shoot the films again. And you can also check that posterior. If the spinal process is all lined up at the back, you'll see this lines up, despite the fact that in the front they don't. If this lines up at the back, it's a pseudosubluxation. It's not a true subluxation. Scawara. So spinal cord injury without radiologic findings. Radiology corresponds mostly to plain films and CT scans. 2/3 of the kids with this will still have an abnormality on an MRI, but that means there's 1/3 of kids who will have an injury but will have absolutely no abnormality on any imaging you can throw at them. It's really scary. These are kids where there was either transient neurologic signs at the scene that then went away and you see them and they're totally fine, totally normal, or persistent signs that have a normal set of C-spine x-rays and a normal CT spine. We think, or at least I don't, but the neurosurgeons out there have figured out that they think it's because everything is so much more flexible in a pediatric spine that you can actually end up hyperflexing, injuring the cord, but then everything goes back to the way it was supposed to look. And even the ligaments aren't necessarily disrupted, but allowed enough movement that there was a cord injury that occurred. So really, if there was ever a documentation of an abnormal paresthesia or weakness or numbness or anything that seems funny, just leave them in their collars and call neurosurgery and let them decide what they want to do. Even if the kid is completely normal, has a completely normal exam when they get to you, if anyone ever recorded some kind of finding that seems like it was a more focal neurologic sign, they stay in the collar and neurosurge sees them. Exposure. We talked about this a little bit. Because they have such a large surface area to body mass ratio, they're going to cool down very, very quickly. So you just have to cover them and warm everything. The air, the fluids. Sometimes you get a bear hugger on them if they look like they're cold, or even put the bear hugger under before they even come in if you know they've had a prolonged exposure time. Just have to think about that more than in an adult. Do we have time to talk about pediatric pain? Okay. It's sort of funny that we talk about this more in kids than in adults because we shouldn't torture adults either. But there's good evidence in children that there can be really long-term results from pain. They've shown in NICU babies that even after a couple of IV pokes, their response to the next IV poke is exponentially higher. Kids can have post-traumatic stress disorder from pain afterwards. It really changes their whole interaction with the medical system from the word go. So if we can try and get on top of the pain early, it can really change their whole hospital course, especially for a trauma patient who may be having a prolonged hospitalization, may have multiple procedures, may need rehab. You know, we can really make everything easier as they go through the medical system. And it can cause all sorts of effects. So you want to be able to examine your patient and figure out what the problem is. If you have a child in pain and they're going wild on the bed or completely shut down and won't even look, it can make it that much more difficult for you to figure out what's going on. Interestingly, they've done studies comparing child's perception of pain to their injury severity. No relationship. So you can have children who have bad injuries who actually maybe are managing the pain, and you can have kids that have very minor injuries, but their experience of the pain is severe. And so it really, you can't go based on just medicate the injury, you have to medicate each individual child. So the main problem becomes rating pain. You have a teenager, you can give them the 1 to 10 scale. Okay, 0 is no pain, 10 is the worst pain, how much pain are you having? A teenager can probably, you know, get with that scale and make it usable. Younger kids are not going to be able to have any clue what you're doing. So we really need to find another way to measure their pain. They've done studies on this as well. So if a parent tells you they're in pain, and you're like, are you sure? And the pain, no, I know my child, they're right. So the parent is very accurate at estimating the child's pain. So you can give the parent the pain scale of 1 to 10, and they will be very close to what the child's actually perceived pain is. So you can use the parent as a surrogate, or you can use one of the special pain scales that have been created for children. I don't know whether most emerge departments have them or not. If you do, that's fantastic. If you don't, I'm going to show you a couple of them. This is probably the most accurate one in the literature. It's called the Brieri Faces Pain Scale. And you give them this and you say, so the one on the left is having no pain at all. The one on the right is the worst pain they've ever had. And then the child points to the face that shows what they feel. Anything from 3 onwards, which would be, so this is 0, 1, 2. This onwards is considered clinically significant pain that should be treated. This is another scale. They think this is less accurate because this is a smiling, happy face. So you've just been in a trauma, you've been taken by ambulance to a hospital room. You might not be in pain, but do you feel like this? Maybe not. So that's why probably this one is a neutral face. You know, this looks maybe a little apprehensive, but not in pain. So this one probably is a little more accurate. You know, this is, I have to apologize a little bit from the pre-hospital talk I was giving last week. They talk about fentanyl and 1 to 3 mics per kilo as being a good safe dose. They didn't have any children who required airway management after this or became more obtunded. So certainly if you're in that range, people use ketamine. I mean, there's a lot of other options. And if you're in the ED, I'm sure you're familiar. But interestingly enough, you know, just splinting the fracture will have a significant impact on the child's pain. Diversion and distraction is incredibly effective in children. If you can find something to talk about, if you can, you know, while someone's splinting the leg, get out the iPad and show the kids the iPad. In a severely injured child, maybe that's not going to be effective, but someone who's got moderate pain, distract, 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 it will work. They use it in the operating room when they're taking the kids in to put them to sleep. It's an incredibly effective tool in children. Don't lie. Don't say it'll be over soon. Don't say it'll be okay. They won't trust you. Accept that, acknowledge that they're having pain. Be realistic about it. That's actually more effective. And then just don't talk about it. Talk about something else. And again, if the parent is willing and wants to be a participant, this can be a good role for mom. Mom, talk to him about the concert you guys went to. You know, talk about the grade 3 trip that they're taking this summer. Talk about anything else, and it can be very helpful. So just a little bit on pediatric. So this is the triage. This is the CDC guidelines. There are 4 levels that you look at. If you find an abnormality in number 1, you go straight to the hospital, to the closest trauma center. Then you move to number 2. If there's an abnormality there, you go to the trauma center. So in kids and adults, there's not much difference. In infants, the respiratory rate is a little bit different, that's all. Otherwise, it's the same. Same with the anatomy of an injury. So if you have an amputation, if you have a pelvic fracture, if you have a severe injury, it's the same thing for kids and adults. Same with mechanism. So one of the differences is with falls, 2 to 3 times the height of the child. So there's less of an absolute number, more compared to the size of the child, which makes sense. And then special circumstances. So you read through all the CDC guidelines, they tell you all that stuff, and then at the end they say, well, actually, if it's a child, you should probably just take them there anyway. So there you go. The New York State guidelines, so there was a meeting in November where they went over specifically pediatric trauma. How do they want pediatric trauma in the state managed? Where do they want them to go? So any kid under the age of 15 meets the guidelines for CDC. So what EHS providers are being told is if they can get to the pediatric accredited center within 60 minutes, that's where they should go. That leaves us with, as of now, the only 2 accredited pediatric trauma centers are Syracuse up and Westchester down. Albany Med is applying for level 2 pediatric accreditation, but we're in the process. We're not accredited yet. Hopefully they will, at some point in the process, put us up on the website. But as of now, we're not there. So those kids go, let's say they go to the pediatric trauma center. You're not in a pediatric trauma center and you get a child. How do you decide keep or go? So what they're saying is, if the child still meets those same criteria and they came to your hospital, they should probably go on to the other hospital. So again, your job is to sort of recognize it, stabilize them, make the communication, and then get them to the pediatric trauma center. They went so far as to also say that they would like the decision made relatively early. So once you've done the primary survey and started to resuscitate, you should have a good idea, are they severely injured? Do they meet criteria or not? And as soon as you know that they meet criteria, that's when you make the call. Now, there was a lot of discussion in that meeting about the reality of the situation. Not everyone has 6 emerge docs and 10 nurses and, 4 unit clerks standing around to help make all of this happen. So the priority is the child, obviously. At some point, you're resuscitating the child. When it seems like there's a good time to step away and make that phone call, step away and make that phone call, but not at risk of the child. What they don't want is, 3-4 hours in, making the call. So there's going to be a sweet spot somewhere in there. And they'd like transfer ideally with 1 hour. Again, it's not just the hospital managing the child that's in charge of that. The ambulance also has to get there and pick up. So it's a system-wide issue, but this is the goal. All right, so pediatric trauma is a significant problem. We're all going to see it. Luckily, we're not going to see it all the time, which is good, but it also makes it harder because it means that none of us are doing this every day. And so there's a level of unfamiliarity that goes with it. Every child is a multi-trauma until proven otherwise, really, is the way we should look at it because of the risk of multi-trauma. They have significant differences in their vital signs and the way they respond to trauma we just have to be aware of. Assess the child. It's really physician's call. If you're happy with a child, there are some rules that will support you in not scanning a child if you don't think they need it. Think about pain management. If you can get on it early, you're going to benefit the child long term. And then triage as per New York State guidelines, do what we can, but our job is primarily the child's safety. Thank you very much. Question.
So in the pre-hospital care setting, what when we're talking about transporting a child to a level 1 or level 2
Yeah.
pediatric center, what parameters, what could us EMTs use to make that decision on, maybe flying them versus driving them, since we're so far away from the level 1, level 2 hospitals?
Well, exactly. So, I mean, I don't know who's in charge of making those calls beforehand. Certainly, if whoever runs the triage on the phone of whether an ambulance or an air is going to get it, if it's a really severely injured child and the child's at a distance where they can't make it anywhere within 60 minutes, those are the kids that probably need an airlift, if it's possible. On the ground, if they're within 60 minutes and can get to one of the centers, then the ground is probably good enough.
Okay. Thank you.
We know Albany Med is a level 1 trauma center, but there's a disconnect between the adult and the peds?
So the resources there are more resources for the adults than for the peds. So the plan was it will be a level 1 adult, but the ACS is actually split up the certification of adult and pediatric centers. So we're going to meet the level 1 adult. We are not sure, we probably could, but we want to play fair, and so we're going to be a level 2 pediatric trauma center. We have full range to achieve a level 2.
Okay, so we're sort of in the middle of the new Westchester St. Francis level 2 trauma center in Albany Med. Mm-hmm. So they're a level 2 trauma center. Do they have any peds capability there, or Albany would still be the better bet?
I think Albany will be, other than the Westchester Pediatric Center, we're going to be the only other one up the Northway that actually has a pediatric accreditation.
Gotcha.
And there's very few differences. There's just a few bells and whistles that a level 1 has that a level 2 doesn't. It's more of a manpower issue, I think. Well, and volume, yeah, that's right. You have to have X number of 200 cases a year, I think, to be a level 1, 100 cases a year to be a level 2.
Yeah, thank you.
Any other questions for Dr. Mills? I also want to thank Dr. Mills, who did most of this prep while she was on maternity leave and just came back 2 weeks ago?
Yes.
A week and a half ago, 2 weeks ago. So special appreciation to you. Thank you very much.